our patient Connie, who will be talking a little bit about her story. So Connie, you want to start off?
Sure. Our host from Tactile Medical had asked me to kind of just give an overview of my story with lipedema. I really thought I was simply a diet failure. I had always, since my first baby, I'd been heavy, had gone up and down the scale, back and forth, but just really got to a point about 3 years ago where, well, actually back in 2017, before the pandemic, feeling like if I didn't do something to lose weight, I was going to die or something. I felt so horrible. Engaged with a endocrinologist, was able to lose about 20% of my then body weight, which is really great, but really hit a wall. And she didn't understand what was going on. I didn't understand what was going on. PCP didn't. So I was kind of stuck. About 3 years ago, we relocated here to St. Louis, Missouri. It's where I'm from, moved back to take care of elderly family. And I was running errands one day and heard a story on St. Louis Public Radio. And there was a gentleman talking about this disease that affected women, and they were only fat in some places. And those places were the same places I was fat, in my hips and my thighs, my legs. And all I heard was a portion of this story. Kept it in mind, went about my business. A couple of days later, I looked it up on the St. Louis Public Radio website, and it was Dr. Wright talking about lipedema. There was a transcript of the interview. There were resources. I think it was the standard of care was on there, as well as some other resources from the Lipedema Foundation. And I was able to send those to my primary care provider and said, I want to know if this is me, or am I just losing my mind and making excuses? Because I was a diet failure. I thought maybe it was just me. Got to my PCP appointment. She said, oh yeah, I've discussed this with the other members of our team here, and you have lipedema. And it was such a relief to know that it wasn't just me. There was this diagnosis. I was able to get in with a physical therapist who's a certified lymphedema therapist at Washington University, and started to do some complete decompressive therapy. Did MLD visits with her, self-MLD, was wearing circade garments, inelastic garments on my legs, and then got in to see Dr. Wright in September. And, he said to me what my PCP said to me, but in a much more comprehensive and scientific way that I had lipedema. And the screening that he did was really helpful, because one of the things he first had his team do was do a sonogram on my legs to make sure that it wasn't something else like a venous insufficiency. But I was also eager to join a study at Washington University that Dr. Wright was contributing patients to, I guess I should say. And I was able to get into that study that fall. It studied metabolics of weight loss in women who have lipedema and who don't, and learned more about myself, how my body reacts. All of the things about my metabolic system was super interesting to be part of that. I was really glad to be putting in some information into the scientific system that was looking at lipedema. After I'd seen Dr. Wright in September, he also got me a FlexiTouch, which I started along with my inelastic compression. And I really did see I didn't notice a lot of pain relief, because when my cat stood on my legs, it still hurt. But I did see a lot of reduction in the inflammation and the fluid in my legs. I had a pair of boots, for example, that I couldn't get on before. And after wearing the compression and using the Flexi Touch and changing up my diet that I was learning in the study, I got them on, which was great. But I completed the study, came back to Dr. Wright, and we started my lipedema surgeries July of last year. Finished those up. The last surgery was the end of February this year. And now I am working on strengthening myself. Dr. Wright also diagnosed me with hyperflexibility, HEDS. So that's what I'm working on primarily with my physical therapist now, is really strengthening my legs, protecting my joints. But the surgeries had such immediate effect. After the very first surgery, which was it was on my thighs, fronts and insides of my thighs, I could go up the stairs without pain. After some of my other surgeries, I could stand in my kitchen and bake Christmas cookies for hours without, it's the practical stuff that really matters. I mean, without having to sit down in between every other batch because it was so exhausting to stand up. Yeah. I still can't keep up with my husband walking. He's a foot taller than me. I'm not sure that I'll ever be able to do that, but looking forward to doing some more things that I have always enjoyed, in particular, getting back to dance class this fall, as I strengthen up and figure out how my body can work for me instead of against me. So that's my story in a nutshell.
Wow, great, very nice. Any questions, Steve or Tom, or any other points, Tom, you want to make about her overall journey?
Well, I mean, it's been great to have you, and she's participated in actually several studies, both we're getting ready. I just want to say a little. We're getting ready to publish that with the metabolic and body composition, and we also looked at tissue markers and saw changes in VEGF receptors in the lipedema tissue, and we're getting ready to publish that. And then she was also, part of the study that we that was published in November of last year, where we showed the mobility improvements that she's describing, and that little humble brag here, won best plastic surgery paper of 2023. So that was published in November of last year, and I just got notification that it was that was the best, considered the best publication for that in the plastic surgery journal that for the year. So
Tom, can you expand a little bit on the type of physical therapy for that, or exercises?
Yeah. So we were looking at knee function, knee mechanics, and as well. Oh, are you talking in therapy or in? Yeah. Sorry. So I do recommend first starting lymphedema and then strengthening, because there is a loss of muscle mass also seen in both lipedema and lymphedema, and so I really feel like that's important.
Tom, I have a question. I'm sorry, Tom.
No, Steve, you had a question, you said?
Tom, quickly. Tom, Julie or Connie, you mentioned that Dr. Wright had diagnosed you with hypermobile Ehlers-Danlos syndrome.
Yeah.
What other manifestations besides joint hypermobility did you have that would suggest that you have hypermobility Ehlers-Danlos? So what extra joint manifestations do you have to support that diagnosis?
Well, I guess, I mean, it's, the classic one that we do in my family is this.
Yeah, so
the-
that's just joint hyper. I'm just wondering, do you have problems such as migraines or irritable bowel syndrome or cold
Mm.
skin?
cold skin, yeah, but not the other two.
You have
Definitely.
stretch marks?
Oh yeah.
And she has super, super smooth skin.
Okay, thank you, Tom. Okay.
But and then the family history, so she's not
Oh.
she doesn't make the full a full syndrome.
The 5 clinical criteria, okay, that you have to have, okay.
Yeah.
But there's a family history, okay. Just curious.
Yeah. Well, I should have mentioned, I've been quite the evangelist about lipedema in my family. Dr. Wright has evaluated both one of my sisters, I have 3 sisters, and one of my cousins. They both have lipedema. And I'm really intent on, making sure my entire family knows there are 24 women in the line from my mother's side, across 4 generations, just in my own family. So, if I can get all of them to at least get checked for it, I would consider myself super successful, because even if they don't have it, they know what to look for in their daughters, granddaughters, etc.
Cool. What kind of
Wow.
surgeries, Tom, did she undergo?
So we call it lipedema reduction surgery. I mean, it's a derivative of liposuction, just different, sort of different techniques. Obviously, the goal is functional improvement and not cosmetic, and really to remove as much subcutaneous tissue. And then we just are very careful. I will often mark and map major structures to avoid injuring lymphatics. That's really how it's technique wise is different than just standard cosmetic liposuction.
Mm-hmm. And somebody's asking, what type of physicians should somebody go to in order to be diagnosed with lipedema? Now, I know you're going to go through some misdiagnosis in your talk.
Yeah. So like classically venous and lymphatic and vascular medicine are the 2 sort of grandfathers of the diagnosis and the but more we're seeing more primary care and others who can diagnose it. But those are
Some endocrinologists and even obstetricians. I'm getting more referrals from obstetricians that are somehow becoming
That is cool.
Yeah, I mean, that's great. I mean, this is
That's
why
amazing.
thank you for Tactile for doing this. This is so important because every time we reach and touch a few people, they become more aware, and that's how they can get treatment.
And where in the treatment process, I'm sure we'll talk about it later, but do you introduce compression and or pump therapy?
So right at diagnosis, compression starts. I used to try and do the pump right at diagnosis as well, but I now all because of what insurance, I always wait a month or 2 before they've done their therapy, and then they can get their, because otherwise they get jammed up and it doesn't work for the patient.
And then what's your protocol after surgery as far as compression and or pump use?
So we're really strict about compression after surgery, because you really that's it. The effect of the surgery is the debulking, but also the resetting of the skin, and kind of the compression the memory of the skin is trained to be, and it also helps. It's very important to control the swelling early on. And then for the first 2 months, we're like, it's got to be 24/7 compression. And then we get more liberal. There are some people who don't need compression or need less compression afterwards. And so it's variable there.
So Connie, are you still using your FlexiTouch?
I am. In fact, I used it the day before yesterday and have actually traveled for business quite a bit in May, and I take it with me because, doing airplane rides can leave me really, really swollen up, and find that the FlexiTouch really helps me process that, and then I can work better the next day with my colleagues on site.
Okay. Well, why don't we move on? Tom, if you want to start sharing your screen, and Connie, thank you so much. Obviously, you can stick around as we mentioned
Yeah.
earlier. And we're going
That
to
was excellent.
on
was
with
really
the
good.
first talk.
Yeah, Connie. Wow, thank you. That was amazing. And thank you so much for helping helping and sharing your message. I'm moving so I can look right at the camera. And okay, so here goes. So the proper diagnosis is so important. Improper diagnosis leads to improper treatment. And so there are a lot of things that look like lipedema that are not necessarily. And my disclosure is Tactile supported my medical research about 4 years ago. So first, I mean, this lady, larger legs, you can see kind of here in the, kind of like at the knees, a little bit of a lobule. Does she have lipedema? Nope. So what is it? So she's got mad lungs, which is sort of the mirror opposite of lipedema. There's 3 types. Type 1 around the neck, 2 the upper arms and shoulder area, and 3 includes the pelvis and also the legs. So this is so Madelung's is associated. It's really very closely related. It's both a lipomatosis, but you can see here she's got more in her trunk than would be typical with. She's not classically disproportionate like lipedema. It is associated with more insulin resistance and abnormal fat metabolism, even some cardio. We get more diabetes with this. It occurs both in men and women. So there's like really 2 types. There's a type that occurs in men that's really related to alcohol, and then this type that we see in women that's really more of a lipomatosis and acts more like lipedema, but is distributed differently and a little bit more metabolically problematic. How about this? Is this lipedema? Nope. This is Derkham's disease. And again, this is another closely related lipomatosis. So here the fibrosis fully encapsulates the adipocytes in causing lipomas. Edema is prominent and also associated with more insulin resistance. Again, she has more truncal obesity. She does have large legs, and this also affects men and women. But in women, it commonly develops around menopause. Again, probably related to metabolic factors. And lipedema reduction surgery is a little less effective. In some people with Derkham's, they are extra sensitive to any surgical trauma. How about this? Is this lipedema? You can chime in, Steve. Nope. Okay.
I don't know, Tom. Is the patient having pain and tenderness?
She's having pain and a little tenderness, but she actually has iliac vein compression. I mean, if you really look at this, you can see that I'm going to have to talk. Her left leg is slightly larger, but as you know, iliac vein compression can be symmetrical, and there's higher risk of DVTs. But the clincher is that they have abnormal waveforms on their venous Dopplers, and then you have evidence of their luminal compression in the iliac veins. And so this is someone who you know, the lipedema surgery may not improve their pain, especially, and she did get relief with a stent. I mean, I'm very careful about this iliac vein compression because I feel like there are some people that are a little stent happy, some surgeons, but I find that I get I find ones that are judicious, and they really can be helpful in this.
Yeah, Tom, can we go back to, I certainly agree with everything you're saying, but still women get lipedema and women can also get concurrent left iliac vein compression syndrome. When I look at this somatotype, that looks like a lipedema somatotype to me. So does she have right leg pain and tenderness? Does she have easy bruising? Because she could certainly have both.
Well, yeah, that's right. And that's an excellent point. And actually, I think she probably does have both. So, but I'm using this to, you know, I mean, but she has both, but it could be, yeah, it could be, you know, the thing is not everything that causes large legs or swelling and tenderness is lipedema. That's more the point than, but I agree with you. And I do think, I suspect I have to check her records, but I may have diagnosed her with lipedema and iliac vein compression. So, now this, I mean, clearly this is how disproportionate. I mean, she's got no fat up top and very large legs, swollen. Surely this is lipedema.
She having pain, easy bruising?
She does have a lot of pain in her legs and heaviness and tenderness in her legs, and some bruising also. But she's acquired partial lipodystrophy, and she and this was diagnosed with low C3 complement and biopsy. And I have to tell you, she did have a surgery that did not help her. So you know, she has the fat loss in her upper body, and then the fat hypertrophy in her trunk, and really, as I said, the lipedema reduction didn't help her. How about this? Is this lipedema? Well, no. I mean, she could also have some lipedema, but she's mostly obesity and lymphedema. And so you can clearly see here she's got fibrosis and cuffs down here. It extends onto her feet. She's got these lobules. These I call them like pseudosarcomas that really only occur with they can occur in lipedema that's also complicated with some lymphatic impairment. So lymphedema is primary or secondary. Most common secondary causes are obesity and venous disease and trauma, and lipedema is a less common. Lipedema and cancer are less common. So secondary is far more common than primary, and primary most often affects the hands and feet, and or spares them, and more often their hands and feet are spared with secondary lymphedema.
So Tom, I mean, obviously, I can tell you, I probably wouldn't do very good here if I was taking a test. And you know, one of the earlier questions was like, where should these patients go for diagnosis? I can tell you that any vein doctor probably would miss the diagnosis and misdiagnose most of these patients. So I guess, how do you get the education out, number one? And number two, are there people like you or Steve who have a much higher experience in lipedema, and how can, you know, the physicians get trained in this, in identifying the different causes of what some of these patients look a little bit similar?
Yeah, no, so I think it's very important that we, vascular medicine, venous and lymphatic medicine, we're the the fathers of this, and we need to lead the charge in proper diagnosis and recognition of this disease. And I think and diseases and this constellation of diseases, but they're all in our wheelhouse. I mean, iliac vein compression can be diagnosed by most vein doctors. Obesity, lipedema, and lymphedema can be diagnosed. Honestly, I was stumped by the partial lipid dystrophy, and it was only, I was just so underwhelmed. I did, as I said, I did a lipedema reduction surgery on her, and she got no improvement. And then is when I started scratching my head, and I said, this is going to be a teaching moment, because this is not, she looked like, and she'd also previously been diagnosed by another doctor who was well known to diagnose lipedema, but I was wrong. And
it seems like it's more important, obviously, for the correct diagnosis if you're going to treat it. And again, on the treatment side, most vein doctors don't do this.
Right.
It could be a plastic surgeon. And even on the plastic surgery side, I don't know how many plastic surgeons would be able to differentiate one versus the other to offer the right treatment.
Well, and so even if it's both, you're going to know. And so, every one of these, except for maybe the partial lipid dystrophy, you could be argued they still have lipedema. And I think that's fair. But so if you recognize the different presentation when they have more truncal obesity, such as in Madelung's or Derkham's, then you're going to know there's more insulin resistance, and you're going to be more aggressive with low carb diet, with maybe the insulin sensitizers like metformin or Wegovy or GLP agonists, and you're gonna be more aggressive with that, and you're gonna also maybe limit their expectations of what they could get. I don't think it's wrong to treat their lipedema if it's cohabitating with iliac vein compression or Madelung's or Derkham's, but then it's just. You have to be aware to do the best for the patient. It's helpful to recognize these other lookalikes. I think is very helpful. So this is lipedema with a secondary lymphedema, and maybe a little secondary obesity. But I think it really started with lipedema and then progressed to lymphedema. But these, Steve would agree, these hardened nodules, they're part of lymphedema. They're not part of classic lipedema. Okay, here, lipedema, yes and no. So she also had obesity, and so obesity is the most common disease. Again, more. There's visceral fat, not just the accumulation in the legs. It's increased risk with diabetes and other cardiovascular diseases. So this is the same patient, before and after bariatric surgery. Now, she has pure lipedema. It didn't, the bariatric surgery, her obesity is gone, but she is just sort of kind of real classic lipedema. So in summary, there are a lot of diseases that look like lipedema, but there are at least variations that, like Derkham's and Madelung's, and that should be looked for, so that every photo that looks like lipedema, isn't just assumed to be just lipedema. And this is difficult because lipedema is a descriptive diagnosis, and we only use descriptive criteria. But these descriptive things can also be caused by other diseases. I hope I didn't go too long. Thank you for your
No.
attention.
That was perfect. Thank you, Tom. Steve, any questions?
Not right now. We can bring them up afterwards in the discussion period.
All right. I'll ask a couple of these that are out there. Do you typically do a skin removal after liposuction for lipedema reduction surgery?
No, most people do not need that. I mean, I would say, 5% or 10% that need that. But no, most don't need it.
Okay. And are there any genetic markers or metabolic markers that are strongly specific or sensitive for lipedema diagnosis?
Well, there's some things that are there's 9 candidate genes, and there's one, the RKC1, that I think is very interesting for lipedema. There's also, we get confirmation with InBody and other bioimpedance markers, and then ultrasound, we can see changes in the structure of the subcutaneous tissue with lipedema. But those are really just reserved for people that do a lot of research right now. I don't think we have a great ready for the masses diagnostic tool.
So, I mean, I think we've talked about it in the past too with Steve and you. So basically the main things is a clinical diagnosis with lipedema, right? The typical body habitus, the symptoms of pain and easy bruising to make your diagnosis.
Yeah, the pain is critical. Yeah. The German Vascular Society would argue that if you don't have pain or tenderness, you don't have lipedema. They'll call that lipohypertrophy instead.
Any role, Tom, for getting these patients in a weight reduction surgery or dieting before liposuction, or?
Yeah. So like the people with obesity and lipedema, I think it really is better to treat the obesity first, because that's going to make treating and controlling the lipedema better. It's sort of, it's hard to go by BMI by that, because just pure lipedema can give you a BMI in the mid-30s if they're very, but I would say most, but once they're in the high 40s, I'm going to recommend, weight loss. My cutoff's at 50, where before I will not do surgery at 50 or above, because I'm going to want them to do weight loss. But even in the 40s, I'm going to recommend, considering these GLP-1 agonists or even possibly bariatric surgery.
And one more question before Steve pops up his slides. Or Steve, if you want to get there when you're done typing.
Okay.
Post liposuction, compression, we mentioned that you do afterwards, but what type? 20, 30, 30, 40?
Most of them are 20, 30. And some on the sometimes when we do the calves, we will do 30, 40, but that's our goals.
All right, well, let's get started. So my topic is lipedema. Is it a connective tissue disease? Now, hopefully by the end of this discussion, I'll be able to convince you it's a resounding yes. All right, so just to make sure we're all on the same page, there are 2 types of connective tissue diseases. There are autoimmune connective tissue diseases, and there are inherited connective tissue diseases. I'm going to be referring to the latter. The heritable disorders of connective tissue, which includes lipedema, I would submit, are a heterogeneous group of conditions caused by defects in the structure and synthesis of extracellular matrix elements such as collagen, elastin, and mucopolysaccharides. Now, of interest, up to 60% of patients with lipedema have a first-degree relative with the disorder. So fulfilling this inherited predisposition, again, suggesting of a connective tissue disease, an inherited connective tissue disease. So I want to point out that in the United States standard of care lipedema consensus document, statement 1.1 was as follows: lipedema should be regarded as a loose connective tissue disease versus a disease of just adipocytes. adipocytes, excuse me. Fat is a loose connective tissue. Very important that you recall that. In addition to containing adipocytes, loose connective tissue has an extracellular matrix of fibers such as collagen and elastin that support, protect, and connect tissue. So very similar to what I just got through stating what defines an inherited connective tissue disease. So let's look at the evidence that could link lipedema with connective tissue diseases. Now, I find this to be a very helpful schematic on the connective tissues. We have loose connective tissues, we have dense connective tissues, and we have specialized connective tissues. Under loose connective tissues, we have areolar tissue and adipose tissue. Both of these are critically relevant to the patient with lipedema. Under dense connective tissues, we have tendons and, importantly, ligaments. And then finally, it may surprise some of you that specialized connective tissues include lymph, also germane to the lipedema patient. So here are three just highly illustrative examples of this unique pear-shaped somatotype that plagues the lipedema patient. And as previously referenced, curiously, these patients have an inordinate amount of pain and tenderness, and the fat tends to be diet resistant. So these patients have disease dysfunctional fat, which is a loose connective tissue. Another check that there's homology between these two disorders. As we also previously referenced, up to 80% of these patients have a tendency to easy spontaneous bruising. Now, why would this occur? Well, because the supportive or dysfunctional supportive tissues around the capillaries and small veins lead to associated dilatation, friability, tortuosity, with an inherent tendency to rupture. Dysfunctional, loose connective supportive tissue around the capillaries and small veins. Another check suggesting that lipedema is a connective tissue disease. In this landmark study by Dr. Karen Herbst and Associates, she identified that 50% of patients had a pathological hypermobility Batten score of 5 or greater. And here are three just highly illustrative examples of a patient of mine with lipedema, and note the excessive joint hypermobility. And as Tom referenced, go over here to the right, and with our X-ray vision here, this skin is soft, it's translucent. You can see right through the skin and see the underlying vein. So this associated joint hypermobility suggests dysfunction in not only the loose connective tissues, but the dense connective tissues as well, because these are what compose the ligaments and the tendons. And by the way, the dermis is actually a dense connective tissue as well, and it's see-through. And so next time around, when Dr. Wright decides to co-author the standard of care for lipedema in the US, I'm going to recommend that there's a revision stating that lipedema also affects the dense connective tissues in addition to the loose connective tissues. Look at these examples of hypermobility in a patient of mine with lipedema. Incredible. So here's a very characteristic morphological abnormality of the patient with lipedema. If you looked at all those ones that Tom showed you, they all had needs that look very similar to this. Now, of note, none of these patients are obese, and yet they have associated knock knees, also known as genu valgum. And this one has excessive extension beyond 10 degrees, referred to as genu recurvatum. So why are these abnormalities occurring in the setting of lipedema, even in the absence of obesity? Why would this occur? Well, because of dense connective tissue disease dysfunction leading to abnormal ligamentous laxity. Similarly, patients with lipedema, even ones that are not obese, often have associated foot pain in association with pes planus, or a flat foot, as you see in these two examples. They also suffer from ankle pronation as well. And ankle pronation a lot of times is easier to see when you look at the patients in a posterior view. There's a great example of ankle pronation. Why do these patients have foot pain with pes planus and ankle pronation? Same reason. Dense connective tissue leading. Tom, a lot of your patients with lipedema have foot pain? It's very, very common.
Yeah, very common. Yep. Mm-hmm.
Yeah, okay, good, Tom. All right. So here's another manifestation of these clinical abnormalities. What I'm showing you here are these reducible calcaneal nodules referred to as pesogenic papules. And these represent herniation of fat through dysfunctional dense connective tissues resulting in dermal laxity. If you look closely, sometimes you'll see these on the inner side of the wrist as well. another check that there's something wrong with the connective tissues in the patient with lipedema. And of interest, if you look at the diagnostic criteria for hypomobile Ehlers-Danlos syndrome, one of these is the heel. So again, some homology here between hypermobile EDS and lipedema. Connie, do you have pisogenic papules, by the way? See, a lot of times lipedema, I'll let you answer. Go ahead.
I was
She must be
looking at your slides before the presentation and haven't had a chance to take a mirror to my feet yet. But so many of what
Yeah,
the
you
things
got to
that
take a mirror, because if
so many of these
if you
things
try to
I
look at
recognize myself.
oh, good. Because if you try to look at these when you're sitting, you're not going to see them. You know, pisogenic means pressure. You got to stand and give some pressure in order to get the mirror, like you mentioned, or have somebody else look at the back of your heels. Good. I'm glad we talked about that. So varicose and spider veins often complicate the patient with lipedema. In fact, this previous article I referenced by Dr. Herbst, 100% and 72% of her patients with stage 1 and stage 2 lipedema manifested. You go back to the U.S. Lipedema Standard of Care Consensus Conference, Statement 5.4 recognizes the association of venous disease, a multitude of venous diseases, including varicose veins, spider veins, and even venous insufficiency. And here are 3 wonderful examples of patients with lipedema that all have excessive, even has associated lipodermatosclerosis. So why would this be occurring in the setting of lipedema? Vein dysfunction. Well, because that vein wall is composed of and supported by dysfunctional loose connective tissue. It all adds up. And by the way, patients with Ehlers-Danlos syndrome, another check, if you will. So here's another consensus statement from the US document. 1.8, a microangiopathy of blood and lymphatic vessels underlies lipedema pathology. Specifically, there are increased numbers of dilated, leaky micro blood vessels and lipedema that contribute excess. And additionally, and although somewhat controversial to some, there's impairment of lymphatic outflow in lipedema that contributes to excess fluid in the extracellular matrix. Now, why are these associations occurring? Well, because of associated underlying dysfunctional loose and specialized connective tissue dysfunction that affects evidence for these comments. So here's a really eye-opening 2019 article where the authors identified that the capillary diameter of patients with lipedema was statistically larger than that of weight-matched controls. And note that these patients did not have obesity. If you go by a lot of the German literature, they'll state that the lymphedema that can complicate lipedema only occurs in the setting of obesity. But yet I'm showing you some data here in non-obese patients that they have increased capillary diameter. Why do they have increased capillary diameter? Dysfunctional supportive loose connective tissues. Full histological representation of dysfunctional dermal skin vessel lumens. Now, this is actually obtained in a patient with stage 1 lipedema with a BMI of only 26. I am going to once again state this patient is not obese. And we're going to be talking about lymphedema. And let's review the histologic phenotype that we see here on the screen. The black arrows represent plump endothelial cells. That segmented black arrow indicates inflammatory cells. So even in a patient with early stage 1 lymphedema, they have inflammatory cells. It's an inflammatory problem. And most importantly, that white arrow spaces, use wide and perivascular spaces. What do you think resides within those wide and perivascular spaces, Tony? Tony is undoubtedly thinking excess interstitial fluid. So, not surprisingly, the authors concluded that lipedema may be an early form of the discussion, if you'd like. Now, here's a 2022 study that underscores the consequence of dysfunctional loose and specialized connective tissues in the setting of lipedema. Now, note here, this is a 2022 study, very contemporary, excellent study, and note that the BMI patients are not fulfilling the diagnosis of obesity. It was a pilot study, 20 individuals, stage 1 or stage 2 lipedema, who had not progressed to clinical fixed lipolymphedema. Their lymphatic vessel anatomy and function were assessed by Nerfly and compared to that of controls. The results The lower extremity lymphatic vessels in overnight showed intravascular pooling, and the propulsion rate significantly exceeded those of control individuals. So why do you think this was recurring? Well, I think it's likely that this associated microangiopathy was flooding the interstitial space with fluid, causing a compensatory increase in contractile and dilated larger lymphatic vessels. Makes sense to me. And the image there at the very top hand right of the screen shows a nice illustration of a dilated lymphatic in a patient with stage 1 lipedema that is not obese. Here's a 2020 reference that lymphoscintigraphy and lipedema. Some of them had lymphedema, most of them did not, but there were 54 patients that had predominantly pure lipedema, no associated lymphedema, importantly, and a mean BMI of only 32, so they were not particularly obese. 75% displayed abnormal imaging with a characteristic tortuous lymphatic, and there is an lymphatic. So why would these patients with lipedema have a tortuous, larger lymphatic? Well, it may go back to the fact that they have dysfunctional supportive loose connective tissue, or it could be this dynamic lymphatic stress as these lymphatics are trying to process this increased interstitial fluid is tortuosity. It's unknown, but this was present in 75% of these patients, BMI of only 32. Now, of interest, the extra-articular manifestations of hypermobile Ehlers-Danlos syndrome eerily parallel those of the signs and symptoms of lipedema. They're both fatigue syndromes. Up to half of these patients have associated functional gastrointestinal illness, such as irritable bowel syndrome. That's why I was asking Connie about that. They're both predisposed to having headaches. Now, of interest in this study, that, by the way, was Dr. Herb's study, I found it curious that 2/3 of these patients with lipedema, now why would a lipedema patient have increased frequent urination? Well, one of the reasons potentially could be that also affects the hypermobile EDS patients is they have pelvic dysfunction from associated pelvic floor laxity. Both patients are predisposed to developing cardiovascular dysautonomic manifestations such as stenosis, cutaneous hypothermia, livedo reticularis, and both of them can have associated immune system dysregulation, specifically mast cell activation syndrome. So when you look at your patients with lipedema, in addition to having swollen legs, if you pay careful attention, you'll note the hypothermia with an unusual erythroacrocyanotic appearance. See, those feet are a little dusky, those feet and the calves are a little dusky, quite apparent in this last image that I'm showing you. And in fact, of interest, if you look at data from Vanderbilt, it was just published last year on 700 patients, lipedema patients, 12 times more likely than their weight matched cohorts to manifest cutaneous hypothermia or cool skin, a dysautonomic manifestation. And let's look at, last of all, the manifestations, or the causes of acrocyanosis or erythroacrocyanosis. And let's go through all these and hone in here on the heritable diseases that can cause acrocyanosis: Ehlers-Danlos syndrome and Marfan's disease, both connective tissue diseases. So again, there's some homology here between the connective tissue diseases and lipedema. Another check. So let's wrap things up. Is it a connective tissue disease? I'm going to continue to say yes. And this is because I pointed out here that you have dysfunctional loose, dysfunctional deep, and even dysfunctional specialized connective tissues that affect the lymphatics. Let's review these manifestations. We have joint hypermobility, and so it's in order. Top left-hand side of your screen, I'm showing you joint hypermobility and that soft translucent skin. Look at that vein. There's more joint hypermobility with the reverse pneumosity sign. I'm sure Tom asked all those lipedema patients to perform that in the office when he's assessing for joint hypermobility. There's characteristic pes planus, usually with associated foot pain, mobility. There's our pesogenic papules. There's our erythroacrocyanosis with cutaneous hypothermia. Chronic venous disease with not only spider and varicose veins, but chronic venous insufficiency as well. There's the abnormal vessel phenotype, those widened perivascular spaces containing excess interstitial fluid. Lymphatic is it. Thank you for your attention. I will get out of the share screen here.
Thank you, Steve. Great
You're welcome.
overview.
You're welcome, Tom.
a lot
So-
of information there and definitely very helpful. Tom, you had a question?
Yeah, so I went, there was a Lipedema World Alliance. There was a long, all these experts in about connective tissue disease. And there's a consensus it's a connective tissue disease. And there are also, and there was all these anatomists and such, and they really consider it not, so we, like you said, they were already on to not just a loose connective tissue, but just plain connective tissue disease. So that including both dense and loose connective tissue. So that's already, I don't, you know, maybe just great minds are connecting in the stratosphere, and I don't know. But
I wasn't even aware that conference existed, so.
yeah, so yeah, I know you. I know you weren't on that conference call. Yeah. But
I would
clearly,
love to have participated, though. I wish I could have.
yeah.
But
So-
what do you think about that? Lymph is actually a specialized connective tissue. I think that's fact.
That's very fascinating. And so it's coming out. I want you to know this is part of our Delphi consensus document for that out of the first World Lipedema Congress. And this is what that debate was about. And so we're settling on connective tissue disease in the Delphi. That's gonna be published in the next few weeks.
Oh, wow.
Where's it being published, Tom?
Yeah.
So this is a Delphi consensus on lipedema. What we know of our current consensus, that's what that's about. For it's an international consensus. And I'm sorry. I wish you would have been part of it, Steve, because I think you would have been right in there.
I would have felt at home. Yeah.
All right. Any,
So, Connie, what, as far as those manifestations, are you going to start looking at your list now and see what you may have
take
there?
notes for everything?
I am. I was taking notes and I downloaded the HEDS DX criteria checklist to double check that because it's really fascinating. I do have that super soft skin. You can see all of my veins. But it also means that my physical therapist and I are doing the right thing to strengthen my musculature around my joints so that I don't have to worry about that as much. But yeah, definitely recognize myself in your presentation, Steve.
Okay, great.
Well, I think we've done pretty good with our questions here.
I'm typing up one here right now.
We
Answer.
answered a bunch of them. And we're almost at the top of the hour. Any last comments, guys?
No, yep. Can I answer this one live?
Yeah,
Because I'm a
You
slow
wanna answer
typer. So what do you do for lipedema patients who can't tolerate a lymphedema pump or compression? And so compression's so anti-inflammatory, and so even just starting with the lightest compression, even like less than medical grade, like 10 to 15, and getting them, and also the weaves tend to be more tolerated than the straight elastic. And then also the inelastic compression tends to be tolerated better. So those Velcro wraps. And then once they're tolerating, then you can add on, and then they find that they can tolerate a pump. So it's really kind of, sometimes you just have to sneak up on it.
And how about recurrence after liposuction?
So
Great question.
yeah, so it can occur. That's why it's really important it's a systemic disease, and there's no liposuction or lipedema reduction doesn't cure it. So they have to really embrace the lifestyle changes, the anti-inflammatory diet, the compression, the exercise. Once what I mean, they get a new lease on life, but they can backslide, and that's less common if they've really embraced these things, and that's why it's so important to embrace them before the surgery, because they're going to appreciate the benefits of them, and then they get this like burst of improvements, but to maintain, they still have to do the lifestyle changes.
All right. I think we're pretty much good here. Steve's typing the last. So I want to thank everybody, especially Connie. Really great story, and thanks for sharing. I mean, this is a great educational experience, hearing it directly from a patient and their experience, the journey, and the options that people have to manage this pretty debilitating condition. Steve, Tom, excellent job as always, and thanks again for Tactile for really
Tony, keeping things under control.
yeah,
Great
Thanks.
job.
yeah.
Yeah, happy Lipedema Awareness Month. Connie and I are wearing purple for Lipedema Awareness Month this month.
Yep.
All right, guys, have a good night, everybody, and please visit the Tactile Educational website for access to this recording
I
as
got
well,
one type.
and also to look up any future events, that educational programs that are coming up. Thank you so much.